However, the WHO advises to use this only when you are performing procedures where there are aerosols generated. So this was adopted by the National Outbreak Management Team in the Netherlands, and it was decided that also just a splash-resistant surgical mask would be good, would be sufficient when taking care of COVID-19 patients. So we were very much helped with this because the splash-resistant surgical masks are easier to get than the FFP2 N95 masks. However, another problem arose with this. First of all, many people started debating about this recommendation from the WHO. Doctors are always critical, and many doctors are reading the COVID literature, and this was a publication in the New England Journal of Medicine that got a lot of attention, and many people started to doubt the recommendation of the WHO and started also to doubt our Dutch policy. This study showed that aerosols containing viable virus remain, that the virus remains viable for up to 3 hours. However, and this is also explained well by the WHO, it is a study done under controlled laboratory conditions using a high-powered machine, and it is not at all reflective of what's happening in a normal situation. However, these kind of publications cause for us a lot of problem because we have to start explaining all the doctors and also the nurses in the clinic that it is really safe, that what we are doing, it is okay, and that this is not something that is applicable to care in a hospital. It's a different situation. So as I said, when the new recommendation was launched from the however, as I already said, when there are aerosol generating procedures, then it's necessary to use a N95 mask to protect against possible virus containing aerosols. And then of course you can debate what to do with the patient room. What are aerosol generating procedures? So then this discussion started, and one of the recommendation, it was okay. Everybody understood, okay, aerosol generating procedures, fine. When you look in the document of the WHO, they give some examples: tracheal intubation, non-invasive ventilation, tracheotomy, cardiopulmonary resuscitation, manual ventilation before intubation, and bronchoscopy, and I think the OptiFlow treatment was added to this very recently, and also nebulization. But then again, many medical specialists starting to thinking about this, and about their own expertise in their own area, especially the doctors that are working in the nose, throat, ear area, or dentists as well. And everybody's starting to think, well, there's virus there, and I'm also also working with these mucosa, and I think I'm also generating aerosols. So basically everybody is, or many medical specialists start to feel unsafe and are demanding again an FFP2 mask instead of a surgical mask. So this is a very a tricky area that we're still dealing with, because we really want to reserve our very limited FFP2 or N95 masks to the doctors and the nurses in the clinic that are really working in the ICU, for example, and are really doing the procedures that are described here. So that's a constant challenge for us. We're still working on that. Another thing is that we are now, especially for the people that are using the FFP2 and N95 masks, we really want them to use them correctly, just like Dr. Lily explained. And we every week we get a different mask. It's incredible how many masks there are on the market, and they all have a different shape. They have different a way of making or fitting it on your head. It is incredible. So what we noticed is that every time you have a new mask, from a new distributor or fabric, we make an explanation on how to put it on. It's exactly what the previous speaker said. It's very important that people know how to put it on. And when you have a new mask, a new shape every week, then it's very challenging to keep on explaining how to do this for the healthcare workers. So we now have almost a museum of masks and a museum of possibilities how to put it on. But we keep on doing it, and we keep on explaining it to make sure that it is used in the correct way. So then I just saw in the presentation of Dr. Lily the complete procedure, how to put it on and how to put it off, all the PPE. So I thought I put this picture in, although it's in Dutch. Sorry for that. But this is what we use for all in all indications. Actually, we're not using risk specific adaptations. So whenever people are dealing with COVID patients, this is what they do. So they put on a mask, and the only difference is that when you're just doing the work without an aerosol generating procedure, it's the splash resistant surgical mask, and when you're doing the aerosol generating procedure, it's the N95 mask. Then you put the gown on, the gloves, and then the goggles, and that's it. So we don't use any boots or whatever. And this is when people leave the room, because we still have one patient, one room. So we don't have big rooms with many patients. So for every patient, people put it on, and then when leaving the room, they put it off. So taking off the gloves, taking off the gown, disinfecting the hands, and then in the corridor, they take off the goggles and they take off the mask. The goggles and the masks are put in a special bin, because we are reproducing them or disinfecting them, and these are used again in the clinic because of the shortages. So these are the bins where we collect the goggles. This is for the goggles, this is for the masks, and this is for other trash. At the moment, the goggles are disinfected, are cleaned and disinfected by medical students who are sitting on the ward and helping us. And the masks are taken to the central sterilization department, and they are sterilizing the masks. And at the moment, at this specific moment, we still have enough new fresh masks. So we will only introduce the reprocessed masks when it's not, when there is no other possibility. So how can we sterilize these masks? Well, first of all, the people at the sterilization department, they make a selection, or they check if it's visually dirty. Of course, when there's lipstick or any dirt on the mask is still thrown away. But when it looks okay, then it's sterilized by, well, there are several procedures. This is the one that we use for the 3M masks. It is with the steam sterilization of 121 degrees for 15 minutes. The problem of this sterilization of used disposable masks is that for every different mask, you need to validate it. For the 3M masks, this is a good method. This is validated. This is also described. This is a document that is open access, and they describe how they did it, and they also describe that they validated it. So with the particle count, so the mask was still having a good function, and also it was really sterilized. So they and the fit was still okay. So, but for other masks, we're also having mask of Call Me. I have never heard about it before, but we now have Call Me N95 masks. And when you try to sterilize these with the 121 degrees Celsius, then it does not work. So then you have to look for another method and to validate that method again. So it's a bit of a complex process, but we're doing this. So we have a backup of quite some masks now in case of, we're completely out. So we have a lot of other shortages. Gowns. Some hospitals in the Netherlands are also sterilizing their gowns with this steam sterilization. We are trying, or we have transformed old laboratory coats into gowns for certain groups, and these are used and then are taken to the laundry service. So that's one solution. So the goggles, this is what I already explained. They are cleaned and disinfected by medical students. We have a shortage of alcohol-based hand rub. This was already clear a couple of weeks ago. So we had a fabric close to the hospital that offered to produce it. So they're producing it. We asked our pharmacist, but our pharmacist did not have the possibilities. I was a bit shocked by this, because I know in the Chipta Mangunkusumo Hospital, the pharmacy can make the alcohol-based hand rub by themselves, and they're doing a good job. But this was not possible here. And of course, and this was already mentioned, I think the last time, is that we have shortages of swabs and other materials for testing. So for the PPE, we have a national task force under the umbrella of the Ministry of Health. And for the laboratory materials, it's the same. We have another task force also under the umbrella of the Ministry of Health that helps us with getting swabs and getting the license buffer, and trying to produce that also here in the Netherlands. There are also some initiatives to produce the masks here in the Netherlands, but as far as I know, it's not successful yet, and it's not used in the hospitals. But I hope that will also yeah, be developed. What we're also doing is we're counting the use. So we are doing observations in the ward, of course, to see if everything is going in the correct way. And yeah, seeing if the people are not using the PPEs. Yeah, it's difficult to say, not for the wrong reason, but in an abundant way. We really try to use it in a limited way. Also for the other indications, we still have around 300 patients with non-COVID related care. There are also patients in isolation, of course, for resistant microorganisms or for TB. So we also watch them and see if everything is going in a good way. And what we also try to do is to de-isolate the patient whenever this is possible. Especially patients in intensive care when they are already 3 weeks in our hospital. And then we try to repeat the PCRs, both of sputum samples and of the nasopharynx throat. And if it's negative for 2 times, so 2 days, 2 samples, so 4 samples in total. When these are all negative, then we stop the isolation, and that also reduces the use of PPE in a good way. And it's also helpful to make the patient recover, so he can start a revalidation process without the isolation measures. And what we're doing as well is we test the healthcare workers when they have mild complaints. And this is because we want to make sure that whenever a healthcare worker is positive, that it's not because of insufficient PPE use with the patient. So we are analyzing all these virus strains, and we're checking if this is a community-acquired strain or from a patient that the healthcare working was caring for. And until now, we have not seen any transmission from a patient in isolation to a healthcare worker using these PPE that we are using at the moment. So this is also to make the healthcare workers, to give them a feeling that what they are doing, that it's safe, and they don't need to worry about that. So, and a short note on the social distancing in the hospital. I think it was Dr. Rini that was also showing the waiting area for the patients. This is what we're also doing, but not only for the patients, also for the healthcare workers. This is one of our technicians measuring. We use the 1.5 meters, and we're not allowed to drink coffee or to eat our lunch in a room without 1.5 meters of distance. And this is also to avoid possible spread between healthcare workers. So not only the doctors and the nurses, but also people in the lab and people in the facility, the other departments. Also the non-COVID departments, of course. And this is a poster to remind all the visitors to keep a safe distance of 1.5 meters because of the coronavirus. So what I've also been seeing is that we're all very, very busy. And I see a lot of infectious disease specialists and internists. Of course, they are starting research for all kinds of treatments. And I think my colleagues have started a very beautiful research about the use of plasma of recovered patients to help the very sick patients. But I've noticing that we are really running, and but we are still also dealing with many questions, and this relates to infectiousness of the patients, about this PPE use. Are we doing enough, or should we do more, or can we do less? And I think it's good to keep in mind that at some point it's also good to start some research on that, and to transform what we're learning now in the clinic and in our daily lives into knowledge that can be used by other people as well. You've also seen many publications now, also that are not even peer reviewed, but getting a lot of attention. And I think not all of these are of a good quality, so that makes it also difficult. Sometimes it gives you more questions than answers. So, but it would be, I think, a good idea to join that flow as well. So, and my last note is stay safe and healthy. And I've noticing that it's not this is not something for the short term. The virus is going to be with us. Well, it's not. The virus is not going to leave our countries, I think, and we have to deal with it. So it's not even a marathon. It's going to be a lot of work for all of us for a long time. So we have to help each other a bit. So thank you for your attention, and I'm giving the word back to Dr. Anis.
Thank you, Juliet, for the very informative presentation. And next, kita sampai pada sesi diskusi. Ya, sebenarnya acara kita ini akan berakhir rencananya adalah pada pukul 14.30, tapi mengingat mungkin banyak sekali pertanyaan yang akan disampaikan, maka kita akan perpanjang hingga 14.45. So Juliet, we will prolong this discussion until 2:45. So 15 minutes longer than the plan. Pertanyaan kami persilahkan. Sebetulnya di dalam chatting itu sudah ada beberapa pertanyaan yang saya rasa penting. Jadi mohon untuk bisa dijawab. So there is 95. So the question for Juliet, it is I think. First is how to reuse it. You have explained that the N95 only from 3M that is validated for autoclaving, but it is only once, yeah, Juliet? And how about the other brands? So can you please explain? Juliet?
Unmute. I have to unmute. Sorry.
Okay.
Yeah, the other brands, we're trying to use, what is it? Hydrogen peroxide vapor, which is a very fancy method. So I don't know if that's even available in Indonesia. But that's another method that we can use for the Call Me masks. It is a mask. It's a brand I've never heard of. I will write it down.
Hydrogen peroxide.
Yes.
How to? So just to put it inside the hydrogen peroxide, or how?
No, it's a vapor. It's a vapor.
Oh, vapor.
Yeah, it's a machine. It's a kind of fancy method, so I don't know if that's available in Indonesia, but that's another option.
Yeah, okay. And then the next question is how to differentiate between the genuine and the fake masker.
Yeah. We have the National Task Force, And the National Task Force is checking all the masks that are entering the Netherlands. And that only after the check, these are distributed over the Dutch healthcare institutions. And this check is, of course, with the particles. It's a fit test, and it's just by visual checking if the strings are okay. And so this, and of course the way it is written on the paperwork, the paperwork should be fine as well. So these are the 4 things that are checked nationally by a team, and only when they pass all these criteria, then it's distributed.
Okay, good. Thank you very much, Juliet. Pertanyaan berikutnya adalah tadi tentang pelayanan penggunaan APD, PPE, and ophthalmologist clinic. Maybe Dr. Lely or Dr. Cahyarini can answer this.
Sudah kami jawab, Dok, via chat sebenarnya.
Ya, bisa. Oke.
Oke. Jadi
ya,
itu
jadi dengan atau tanpa tindakan aerosol ya, silahkan.
Iya. Jadi kalau di poli itu panduannya masuk ke aturan APD untuk poli rawat jalan. Jadi fasilitas rawat jalan di ruang kesehatan. Jadi kita untuk petugas kesehatan itu kita pisahkan apakah pasien itu dengan atau tanpa gejala infeksi saluran nafas. Jadi kalau dengan gejala infeksi saluran nafas, maka petugas tentu harus, kalau memang petugas itu tidak melakukan tindakan yang memicu aerosol, maka cukup masker bedah saja, kemudian ada gaun, sarung tangan, pelindung mata dan atau pelindung wajah face shield, kemudian pelindung kepala dan sepatu pelindung. Tetapi kalau memakai tindakan yang memicu aerosol, maka maskernya diganti dengan masker N95. Jadi itu saya rasa standar APD untuk rawat jalan, Dok. Jadi ada gaun, ada masker, ada sarung tangan, pelindung mata, itu wajib. Karena saat ini kita tidak pernah tahu apakah pasien itu memiliki virus corona atau tidak di dalam tubuhnya. Jadi itu APD standar yang harus dipakai. Nah, untuk pasiennya itu dengan atau tanpa gejala infeksi saluran nafas harus memakai masker bedah dan kita harus menjaga jarak minimal 1,5 meter dengan pasien. Dari jawab saya seperti itu.
Terima kasih, Dr. Lely. Baik, saya memberi kesempatan kepada yang lain. Yang pertama saya ingin memberikan kesempatan adalah kepada host dari acara ini, yaitu Surabaya. Silakan, ada peserta dari Surabaya yang ingin menyampaikan pertanyaan.
Ya, mungkin masalah gaun. Ini saya lihat beberapa rumah sakit, gaun untuk nakes sama cleaning service itu ada sedikit berbeda atau dibedakan. Untuk ruang COVID, di nakesnya pakai A, sama-sama gaun istilahnya. Nah, ini barangkali pengalaman di persahabatan, apakah ada juga membedakan antara cleaning service dan itu di dalam pemakaian gaun?
Silakan Dr. Cahyarini.
Makasih Prof. Untuk di persahabatan kalau ruang isolasi kami tidak bedakan Prof. Semua petugas yang bekerja di ruang isolasi baik itu dokter, perawat maupun cleaning service tidak dibedakan APD-nya. Gaunnya juga nggak dibedakan Prof.
Ini ada satu macam gaun ya jadi ya?
Iya.
Oke, terima kasih.
Terima kasih. Dr. Hari Paraton mungkin ada pertanyaan, Dr. Hari.
Satu pertanyaan aja, Dr. Anis.
Silakan, Dok.
Mungkin pengalaman di persahabatan, Dr. Cahyarini, di poliklinis itu beberapa rumah sakit meja pemeriksaan untuk konsultasinya itu menggunakan pemisah kaca atau akrilik. Apakah itu bagian dari kelengkapan proteksi untuk dokternya ya? Makasih, terima kasih.
Iya Prof, iya Dok. Memang di poli kami juga telah dipasang kembali akrilik atau kaca di meja pemeriksaan. Dulu itu kami lakukan tahun 2000-an untuk TB. Terus kemudian muncul tos TB yang kita tidak boleh stigma pasien, akhirnya itu dilepas dan diganti dengan cukup masker N95 saja. Tapi di era COVID ini karena